Hello, I'm Dr. John Kruse, and welcome to today's question and answer session on ADHD and mental health. So, as usual, I'll be summarizing first the three videos that have been re-released this week. And after brief, probably 1-minute summaries of each, I'll be open for questions. I see there's some already waiting there. So the three videos that were re-recorded or resound engineered are caffeine and ADHD, positive illusory bias, and restless leg syndrome. So regarding caffeine and ADHD, caffeine is a stimulant. It's worldwide the most commonly used psychoactive substance. It is in many ways not an ideal stimulant, but we're usually using it at lower doses. So at an equivalent dose, it probably has more neurological issues, more cardiac problems, more sleep disruptive problems, more anxiety than heavy duty prescription stimulants. And dosage may be harder to predict or calibrate. So the thing is to be aware that if you're taking stimulant medications, there may be some interaction between caffeine and your stimulants. Yeah, I'm happy to talk more about that. Positive illusory bias, and I see it generated some good questions and some very thoughtful answers and comments. So positive illusory bias is a condition that was identified in children, primarily boys with ADHD, where they highly overrate their capabilities. And not just do that, so that's positive. It's illusory because it's not consistent with their actual performance. It's biased because it seems to be consistent across multiple areas. And furthermore, unlike general positive self esteem or high self regard, which usually correlates with greater motivation and greater effort on subsequent efforts, that doesn't seem to be the case with positive illusory bias. And positive illusory bias also doesn't seem to be altered by real life performance. So if you do lousy, it doesn't seem to change your view that you're doing wonderfully. There is no rigorous research, but there's lots of speculation as to whether PIB is associated with people who later become narcissists. And the other important, sorry, I do have a cold today. The other important feature of it is that it refutes the notion that absolutely everyone with ADHD has RSD, or is rejection sensitive dysphoria. So there are some people who, even if with ADHD, who have bad things are happening to them, that just slides off their back. They just move on. They don't pay any attention. They just glide through life thinking everything's wonderful. So the third video that was released was on restless leg syndrome. Restless leg syndrome is more frequent in those with ADHD, but it can happen and occur in people without. It's an irresistible urge to move, particularly the legs, usually late in the evening. It is treated by dopamine boosting drugs. And one of the concerns is, even though some of these drugs are FDA approved for restless leg syndrome, there's growing evidence that they may actually perpetuate or worsen the condition over time and increase the dependence on those very drugs. So there are studies and research going on to see whether other agents may be as helpful without causing a perpetuation or a worsening of the symptom. Iron deficiency and other certain medications are associated with higher rates of restless leg syndrome. So those are the three videos that are out there. Again, I'm open to questions on those and other topics. And one other comment, we're still working on getting this subreddit up and going. I guess they have to vet it, and there's holiday delays in doing that. So I see there are questions from Dennis. Hi, Dennis. Dennis asks, can one have anxiety in both brain hemispheres? According to neuroscientist Dr. Robert Milo, left brain anxiety is related to OCD, where right brain anxiety is related to social anxiety. What I would say is I do have a talk on left brain, right brain differences, or understanding of how they operate differently. I'm not familiar with this hypothesis of different anxieties manifesting in different hemispheres. So I can't, to me, it sounds likely to be an oversimplification. And there certainly can be many individuals who have both social anxiety and OCD. So Dennis is summarizing that, in other words, left brain anxiety is equal to right brain deficit, and right brain anxiety is equal to a left brain deficit. Um, yeah, so I'm forgetting. So in the summary about left brain, right brain differences, it's not as simplistic as that the left brain is language and logical, and the right brain is artsy fartsy and illogical. The more fundamental distinction seems to be that the left brain is logical, reductive in its thinking. It breaks things into pieces and tries to reassemble from them, whereas the right brain has a more holistic gestalt approach, and integrates information, but is less verbal in its explanations and integrations of those. That's again, an oversimplification, which may be missing some certain details. So in that regard, could there be different forms of anxiety or ways anxiety is expressed with different deficits in each of those? I'd say possibly, but I'll just leave it there. I haven't seen the work or research that's based on to know, but I will try to look it up later. So hello, Jonathan. So hi, Max. Max says, hello. What's happening neurologically with the body when the body is making a movement you don't want it to make, like restless leg syndrome? Why does the brain block you from stopping that involuntary movement? So this is also, I would say, outside of my area of expertise. So my understanding is that there are that in some of the movement centers of the brain there is activity. Well, there's anticipation of movement centers, which is different than movement centers. Yeah, again, I'd say that's beyond my. I can't comment intelligently on it, so I guess I'll stop there. So Chris Nyquist asks, what's the difference between restless leg syndrome and periodic limb movement disorder? So restless leg syndrome, one is just the timing of it. The restless leg syndrome is usually occurring starting in the evening. So there's a strong circadian pattern. It's occurring strongly in the evenings and before sleep and can continue into sleep. The strong component is a internal feeling or a drive to move. So there's a conscious, a motivational, urging aspect. So it's not just that movements are going. Whereas periodic limb movements of sleep are happening specifically only during sleep, or in highly unusual cases, they're happening during the REM stages of sleep, is my recollection. It's a specific sleep stage. I'm pretty sure it's a REM. So they're only happening during those stages of sleep, even though usually we're paralyzed, most of our body, except for our eyes, during REM sleep. So it's tied to a phase of sleep. And so usually the person is asleep, and usually even upon awakening, it's not a desire to move. It's just that the limbs are moving. So I guess I'd say both of them are most common in the legs, but they can involve other parts of the body as well. So and I don't know I don't know what effective treatments there are for periodic limb movements of sleep, which are also correlated with development of other neurologic conditions that so Carol may give us more information than I had. So Carol has restless leg syndrome and in the process of being diagnosed for ADHD. She doesn't have iron deficiency, which again is one of the common predisposing factors for restless leg syndrome, and that may have to do with dopamine processing and motor centers in the striatum in the brain. Um, so Carol doesn't have iron deficiency, but had it in the past. Restless leg syndrome prevents her from relaxing and reading a good book. So again, it seems it's some caricatures of it that it's sort of silly or trivial. Your legs are just moving, but it can be such an overwhelming um, force that it's disruptful to getting any relaxation or rest. So I'm going to Bibs is taking 90 milligrams of Elvance, which is Vyvanse in the US, so it's dexamphetamine, um, every day, and the effect is mild. I may have to get a higher dose. Doctor told me that a small percentage of people need a higher than normal dose. Can you explain why? So I do have a whole video just on high doses of stimulants and why we should focus on what the drug is doing physiologically for an individual rather than fixating on the milligrams. So a number of reasons people may need a higher dose. One is they may absorb the drug at different rates. So gastrointestinal issues, acidity may have impact. Two is, with Vyvanse, it is activated. The form you're taking it is an inactive drug. It's not activated until red blood cells, enzymes in your red blood cells cleave the lysine, the amino acid, away from the dextroamphetamine. Then it becomes available as the active drug. So I don't know that there have been variants that have been identified, but certainly it's theoretically possible that different variants of that enzyme may have different efficacy in splitting off the lysine. So you may have more or less availability because of that. One of the biggest factors is how long dextroamphetamine circulates in your body. So if you have enzymes that chew it up really quickly and destroy it quickly, then even if you're taking the same amount as another person, you will have less available in your body, brain to work. If, on the other hand, you have enzymes, liver enzymes that are particularly inactive in chewing up the dextroamphetamine, it will last for a longer time, more of it will build up from an equivalent dose. That seems to be one of the biggest factors. That is what genome testing is trying to target. The problems with genome testing are at least twofold. One is, for most of the common enzymes, we've identified common variants, but there are other variants that have been not diagnosed and don't get assessed. Two is that those are looking at the genome. So that's looking at the genetic variants that you inherited, which is very different from what's actually active in your body, which is due to not just genetic inheritance, but epigenetic factors. So you may have a very active form of the gene, but if it's been turned off, so what? It's not acting. On the other hand, if you have moderately low genes that form a variant of the enzyme that has moderately low activity, but for some reason your body has really revved up the production of that and it's being hyperproduced, you may actually chew up the dextroamphetamine floating in your body pretty quickly. So other variables affecting what dose is effective for you could also be differences in blood-brain barrier penetration. So most of the drugs don't just flow freely from the blood in the body to the blood in your brain, that they are filtered out by what's called the blood-brain barrier and need to be transported across that. And then within the brain, there may be variants of receptors drugs are binding to, or variants in number of receptors to begin with, based on genetic or other causes that are predisposing you to this condition. So all of those mean that, again, there's a huge amount of variability between one person's response to a certain number of milligrams or not. So hopefully that covers the big bases, but again, I do have a video on some of that if that wasn't clear. So LFC is just checking in to say that their boyfriend went for his ADHD assessment today, or Thursday, it's going Thursday, or went Thursday, and he went Thursday. He's 52, waiting for results. So again, we are seeing across the nation and across much of the world, a big surge in adults who are finally having assessments for ADHD and discovering that they do have it. The critics claim that we are inventing conditions, but the overwhelming data suggests there are at least 4 or 5% of the adult population who meet full criteria for ADHD, and yet a majority, well, depending on which country, which assessment, and what tool we're using, there's still many of those who are undiagnosed and untreated. Jonathan's asking how big, and I'm not quick enough on what we're referring to back then. So Carol asks, is endometriosis more common in ADHD patients? I don't have the data on that. I do know that a variety of autoimmune conditions and inflammatory conditions are more common in those who have ADHD. So I would not be at all surprised is the way I would say it, but I don't have definitive data in front of me or in my head. Modima Rose, hello again, said, when I was pregnant with my third child, I got restless leg syndrome pretty badly, and my husband would rub a heated muscle cream on my legs, which distracted my brain long enough to fall asleep. So thanks for sharing, and thanks for pointing out that pregnancy itself is one very significant factor for RLS. Most of the individuals who get it during pregnancy, it stops when the pregnancy is over, suggesting strongly that hormonal factors can influence, again, largely dopamine systems that affect this motor activity. And also, thanks for pointing out that in addition to medication strategies, very often massaging, touching, manipulating the leg does help alleviate the sensation. And there are some practitioners who claim that specific massage or muscle techniques not only sort of treat it in the moment, but may have preventive or curative effects. I'm not aware of explicit research on that, but may potentially be helpful. So Jonathan Carpenter asks, how can I be contacted? So my email, YouTube, it's somewhere on the YouTube channel, but it's Dr. John Kruse, DrJohnKruse @gmail.com. What I tell people is I'm not looking for any new patients or accepting any new patients. I'm happy to provide general information, but I don't have a doctor-patient relationship with anyone. So any things that sound like recommendations or suggestions are general information that you should use in consultation with your prescribing medical team. And maybe they will learn something. So Dennis mentions that he's taking 108 milligrams of Concerta and a Ritalin 10 milligram booster. How should I ask my psychiatrist about trying Ritalin SR instead of IR? So the Concerta is a form of sustained release Ritalin, but so I'm assuming we're referring to the 10 milligrams. What are the strategies? One is I would ask, so backing off half a step, it's fairly, even though the rationale for the initial rationale for the development of extended release versions was that people would would simplify the lives of people with ADHD who have particular challenges with remembering, organizing, keeping track of their medications. And particularly for kids, it would avoid the need for a kid to go to the nurse multiple times during the day to get redosed and potentially stigmatized by the nurse or the other kids at school. So the ideal or hope was you could take a single pill in the morning and that would treat everything during the day. Very often there are lag points, so there might be a siesta time. You might not be getting enough coverage. It may not last long enough for you. So it's fairly often we know that, and I have a talk on combination drugs, that people do combine a short-acting and a long-acting version of the same drug. So benefits of the long-acting are not only do they last a long time, but they also tend to leave the body less abruptly and leave less withdrawal reactions at the end of the day. And withdrawal can be a drop in focus or concentration, or in energy, or in mood, or all three of those. Um, so, one reason to switch from a booster or additional 10 milligram dose that's immediate release to extended release or sustained release would be just to have it leave less abruptly. Another might be that we're trying for a greater duration of action of that additional booster. So my thought would be that the strategy is trying to explain to the doctor what you feel you are experiencing from the current regimen and what you anticipate you would see better. And I would pose it that you are willing to do, you are not demanding a permanent switch. You're proposing it as, let's try this for a month to see what will improve. And this is what I'm going to evaluate or measure or assess whether this is successful. Simon says, I was told that untreated ADHD can cause brain damage. Is this true? So it's a well, I mean, the question is open to interpretation in different ways. One simplistic way, and I'm not sure it's the way you're intending it, is we know that individuals with ADHD do incur head trauma, severe head damage, much more commonly than the general population. And it's not just head trauma, they incur a whole range of physical um, accidents or trauma more commonly than the general population. And it seems probably tied into both inattentiveness, so not being aware of everything around you and what's going on, and impulsiveness, so a willingness or desire to go into more dangerous, stimulating, exciting situations. So the two of those do increase the likelihood you will incur brain damage. I think the intent of the question is more, does the process underlying ADHD continue to progress and lead to worsening of symptoms? There we have much less, I'd say, rigorous data. I mean, the common conception is that ADHD is most commonly a neurodevelopmental condition with strong genetic influences, that by early childhood, preschool age, most kids or adults who later display it are already showing signs. The official diagnostic criteria was switched from age. Symptoms had to exist before age 5 to before age 12, not because we think differently of how late it shows up or starts showing up, but just because the ability to accurately recall events, even of parents to recall events from before age 5, is worse than if you allow a cutoff until age 12. So the general conception is, and we know that some kids do largely outgrow ADHD, some kids don't get any better, and some seem to show some substantial decrease. Work by Margaret Sibley and others suggests that across the lifespan, it's fairly common for people to slip in and out of full ADHD diagnosis on a sub-threshold level. So maybe there is that, and that's not clear whether that is a decrease in the symptomatology or brain changes in brain functioning itself, or more due to an interaction between the brain and the environment. So if you find a situation that's working for you, if you have supportive colleagues, if you're on a task or project that really excites you, you're likely to do well and stick with it. So in general, we don't have evidence that ADHD tends to be a pervasively worsening condition. Um, on the other hand, and I have a special video on this about, I think it's titled Brain Damage and Stimulants, there's fairly compelling, more than 30, 40 studies have been published indicating that kids with ADHD who take stimulant medication compared to kids with ADHD who don't take stimulant medication, so the kids on the drugs by the end of by young adulthood are showing signs in multiple areas of brain structure and brain activation that their brain looks and acts more like a normal brain. We can debate whether that's a good thing or not, but that would suggest that drugs at a certain time in life have a protective effect, and that not getting on them early enough may lead to or encourage brain damage, if we want to use that term. Interestingly, um, the term in the, I think it was about the 50s and 60s before ADHD was coined, the term used to describe these kids largely because it wasn't recognized much in adults was minimal brain damage, which pejorative and not helpfully descriptive. So, and Modimo Rose is pointing out that untreated ADHD can not just cause brain damage, it can certainly cause life damage. Absolutely. Can't read the name. Slayman Bisharat says, hello, doctor. Have you considered combining Cymbalta with clonidine or Cymbalta with bupropion for managing ADHD with coexisting anxiety? What would you suggest? So I do have a talk on combining medications. And I do use a fair amount of Cymbalta, the serotonin norepinephrine reuptake inhibitor, not approved for ADHD, but probably as effective as atomoxetine from what I've seen. I don't usually use clonidine. So clonidine and guanfacine are both, and I have a talk on guanfacine, alpha-2 agonists. So they're working on a subset of the norepinephrine system. They seem to work similarly, although there may be subtle additional differences in what they do. The downside of clonidine is that if you miss a dose, so both of these drugs were originally developed as antihypertensives to treat high blood pressure. Clonidine, if you miss a dose, has a fairly significant risk of causing rebound hypertension. And it doesn't just leave you back at the level of high blood pressure you were before. The rebound can be extremely high and dangerously high, so as high as 180 or 200. Guanfacine theoretically has that potential, but it seems to, its interaction on the receptors seems to, the receptor lets go of it more gradually or slowly. So groups that have studied or looked for it find rates of rebound hypertension when stopping or missing a dose much less likely with guanfacine. And certainly people with ADHD are predisposed to missing a dose of their medication. So, I mean, usually Cymbalta itself tends to be an effective medication for a broad range of anxiety, as well as the norepinephrine reuptake action seems to be helpful for many individuals with ADHD. So hopefully or often Cymbalta duloxetine itself could treat both ADHD and coexisting anxiety. Bupropion, so bupropion or Wellbutrin, I wouldn't usually add on to treat coexisting anxiety. I might approach it the other way. If someone was on bupropion for ADHD and having anxiety, I might add on Cymbalta or a pure serotonin reuptake agent. And I certainly would consider buspirone, which is an alpha serotonin 1A agent, partial agonist, which also may have some direct benefits or additional benefits specifically for ADHD. So that may be a more likely combination to help with coexisting anxiety and ADHD. So Slayman's mentions that they've tried a number of stimulants except for Focalin, and Focalin's a form of methylphenidate. So it's not likely to be dramatically different than other forms of methylphenidate, and still struggling with anxiety. So one of the biggest uses of guanfacine under the brand name Intuniv, which is a slow release or gradual release form of guanfacine, it is approved as a single agent to be used for ADHD and is measurably effective in that regard. But one of its commonest uses is for people who have too much anxiety or can't tolerate a stimulant, to take them off the stimulant, get them on a stable dose of guanfacine. If that alone is treating all their ADHD, great and fine. But if it's not, then it's reasonable to resume trying a stimulant. And very often people who could not previously tolerate a stimulant can when once the guanfacine's in place. So, so Max is pointing out that for some people, stimulants at too high a dose can create ADHD-like symptoms and or brain fog, and sometimes lowering a dose helps finding the sweet spot, which is a good point to bring out. And I think it's part of the reluctance among a large number of pharmacists and a large group of people in society to be wary of that ADHD. Someone who's high on stimulants or hyped up on stimulants can resemble someone with ADHD, and that can make people wary or leery of, why should I give someone a drug that it looks like they're already taking? And again, the answer there is that if the symptoms are coming from ADHD, they are usually alleviated by a stimulant. But if they're coming from too much stimulant or stimulant abuse, then it would be right. Piling on more isn't going to help. Um, yeah, I don't usually go into personal life too much, but I am married or something. Yes, so my husband just delivered the dog in the next room. But we'll try to keep this on mental health and neuroscience, although I guess marriage and relationships is part of mental health and neuroscience. That's Cupcake back there, which is also part of mental health. Carol, is it recommended to self-reward when trying to stick to a habit or reach a goal? I feel that sometimes I get more of a kick of dopamine at not following a habit than following it. So your comment struck a note. So I have a patient who, I won't share too much information. They're in their 50s, but have been retired for a decade just because they were in the tech industry and got a very good deal on stock options early on. And clearly a bright person, lots of hobbies or interests, and they have tremendous trouble because now they have no structure in their life, sticking to anything. And they actually mentioned sort of having a contrarian viewpoint, and that actually being told to do something often makes it harder for them to do it, or that they can motivate themselves by doing what they think is recommended not to do. So my answer there is, if self-reward works for you, great. If you know it doesn't work for you, then I wouldn't try to use it. One of the most useful tools that I've been taught, or tricks, is that the best way to establish a habit is anchoring it to a pre-existing habit. So if you want to remember to take your medicine every day and you know you shut your alarm clock off in the morning when it's buzzing at you, or your phone or whatever you're using, then put your medication right next to the phone so you will see it and remember it or associate it with it. And there's lots of videos claiming there's some magic number of 47 and a half times you have to try a habit before it kicks in. I don't think there's a magic number, but there is, often in enthusiasm for a new habit or new activity. People with ADHD get excited and can do it for a short period of time, but they don't do it for a long. But most of us, if we do it long enough, it does become habitual part of us. But often the sour spot, the place that people with ADHD fall off, is, after the initial enthusiasm wanes and the habit hasn't yet formed. So that's the sort of tricky spot where using motivation, using social reinforcement, asking a partner, a friend, someone to remind you. And the difference between a reminder and a nag is how the two of you have set it up ahead of time. So the very same words can come across one way for both parties or either party. But if it's employed with acknowledging, I have ADHD, that means it is harder for me to remember to do certain activities. Can you help provide that reminder? Or nowadays, technology can also. So the other thing it highlights, and I have a talk about dopamine and rewards, and it might be in a talk on video or on um, addiction, that some of our how we talk about neurochemicals, I think, is often more stories than maybe direct, actual good neuroscience. So I know lots of people talk about feeling a kick of dopamine and equate dopamine with joy or elation or excitement. And dopamine's certainly involved in the centrally involved in the reward processes, but it's probably the dopamine itself is more about assessing whether what you expected is what you're getting and looking at the mismatch or the consistency there rather than joy at actual achieving or getting something. And joy probably has more to do with and that and that the endogenous cannabinoid that Max found me the name for and adantamine and anadantamine. I somehow it's not sticking in my head or oxytocin. Someone's going to throw it in, hopefully. I was just writing it the other day, so I can probably spell it out better than I can say it. Max brings up on referring to the illusory part of positive illusory bias. How do you differentiate clinically what's an illusion, delusion versus what may be a belief? There are many people that hold strong beliefs despite proof to the contrary. So the official definition of delusion has to do with an illusion usually has some basis in physical phenomena that you're distorting or misinterpreting what you are seeing, hearing, smelling. The delusion is more in the realm of thought, but it's defined usually as holding on to thoughts in the face of information that shows that these are not true or accurate. Now, there can be delusions that are held by wide swaths of society. I mean, some of them could be ignorant. So, in the days before Columbus, most people believed the earth was flat, or at least in Western cultures. Other cultures had different ideas and beliefs about the structure of the universe. Um, would that be considered a delusion? It was delusional, but it was a widely socially accepted delusion. So some add in that a delusion has to be inconsistent with parts of what's going on. I think it's absolutely fair to say that most of the majority of the political discourse that's happening in the United States over the last year is delusional. You can see with your own eyes direct refutations of what certain candidates or people said and it's delusional to be blaming diversity and inclusion criteria on California wildfires. There's just no basis for that. There's evidence from all sorts of regions to discredit that belief and attribute other causes. Whether or not 52 people pile on and agree with it still doesn't make it undelusional. So yeah, so strong beliefs, if they are contrary to demonstrated fact, are delusional, even if they're strongly held. Lordima Rose is promoting puppies for mental health. So Slurman Bishrat says, how would you work with disoxin? Does it cause less anxiety compared to other stimulants? So disoxin is a prescription form of methamphetamine. So it's not dextroamphetamine. It's not amphetamine, which has dextro and levo components. It's methamphetamine. I would tend to avoid using it because the evidence is pretty overwhelming that it has a higher rate for addiction. It probably has a substantially higher rate for paranoia and psychotic disorders. And whether it's less likely to cause anxiety. So there's some evidence, and particularly getting back to amphetamine, not methamphetamine, but amphetamine, whether levo or dextro, which penetrates the brain better, which has more peripheral body um, stimulation, and which has more central brain stimulation. Theoretically, if it's overstimulating the body, you may have more side effects, more including tremor or other bodily sensations can lead to anxiety, as well as central brain stimulation. So either one by different paths could lead to anxiety. Um, I would be pretty hesitant to jump to that if other stimulants haven't been helpful. So thanks, Max. It's anandamide. I need to probably say it 100 times. I need to get in the habit of practicing that so I can remember it and say it fluently. Yeah, so no offenses taken. I do have potentially more time. Oh, I see. Sorry. More questions are coming in that weren't. So, so good questions so far. If there's not other questions about caffeine or positive illusory bias or restless leg syndrome or life in general. Hello again, Mr. AKA. So Mr. AKA asks, does sodium valproate cause GABA A receptor downregulation over the long term to the same extent as benzodiazepines? So I don't know the research literature. So sodium valproate, originally an anti-seizure medication, also FDA approved as a mood stabilizer for bipolar disorder, also used fairly commonly off-label for explosive anger disorder or mood volatility. And in that sense, many people with ADHD do wind up on it, whether or not they have an ADHD diagnosis. Versus benzodiazepines, which are effective for anxiety and work on a receptor site directly on the GABA molecule. So my expectation would be that benzodiazepines and alcohol are more effective at downregulating GABA A or more directly interacting with it over the long term, but I don't know for sure. Slayman, and I hope I'm not butchering that name, asks, what about TMS or other devices for ADHD? So TMS, I'm not aware of any rigorous studies demonstrating efficacy for ADHD. That doesn't mean it can't be helpful. There's actually a little more evidence on very cheap, portable transcranial direct electrical stimulation devices that you can buy without permission from a doctor, or you don't need a prescription for them. And it's very low current. It's often just a tiny little 9-volt battery, which is giving a electrical stimulation to the scalp and skull, which theoretically is either activating or deactivating brain cells below that, depending on the direction of the flow of the current. I'd say most of the other devices or approaches are experimental. There is neurofeedback has been pushed for years, and there's just another recent meta-analysis looking at neurofeedback for ADHD, failing to find any substantial benefit, but that's largely because the studies have not been conducted very well. It doesn't mean that they might not be beneficial. What else? I mean, my go-to, other than there's clearly a lot of work on cognitive behavioral therapy approaches, and those approaches can measurably help reduce some symptoms of ADHD and can measurably help improve the quality of life for individuals with ADHD. Um, they need to be administered or taught usually by someone who has not just expertise in CBT, cognitive behavioral therapy, but CBT modified for ADHD, just because the standard CBT is not a good match for ADHD because it requires lots of boring homework, lots of introspection, lots of awareness of what someone's doing, which may be hard to practice until your ADHD is under better control. Um, and I've worked with lots of extremely bright, motivated people who would buy a workbook or CBT oriented training book for help with their ADHD. And I don't think I've seen a single case where the person was successful in making good use of it because they would page the book and say, "Oh, I already do that one. Yeah, I use that technique already. And oh, this is a really good one. I haven't thought of that or approached it that way." And they'll find some interesting things and then they won't do the practicing of it, which is the essence of, or one of the essences of CBT, that you have to do these things over and over and over before they become the new default. Otherwise, you're just likely to continue doing what you've done before. So, Modima Rose asks, does being maxed out on a long acting dose prevent a prescriber from adding a short acting dose at the end of the day? So there's nothing, I mean, a doctor, at least in the United States, is allowed to prescribe whatever they think is medically indicated, and they have evidence or thoughts that the benefits are going to outweigh any costs or risks. So, given that there's certainly data of the efficacy of short acting stimulants and long acting stimulants and of combining the two, there shouldn't be any legal restrictions on combining the two. I mean, part of it is that sometimes just different formulation. I mean, so I often criticize the fact that there's 12 or 14 or maybe now 20 different formulations of methylphenidate or dextro and levoamphetamine in different ratios with different release at different times. Some of those really do last longer than others. So I've had people who did get clear benefit from um, Vyvanse, amphetamine-based product, but only got 12, 13 hours a day from that, who got 15 or 16 hours from Mydayis, which is designed to last longer, and that was optimal for them. So either extending, I mean, particularly if you don't consistently need your day to be longer or effective day longer, then it may be reasonable to add a short acting towards the end of the day. And again, usually adding it before the benefits of the short term or the long term wear off is more reasonable than trying to catch up and make, having a drop and then taking your dose. Um, so yes, in general, there should not be restrictions, even if you are at the high end of the dosage range. And again, rather than focusing on milligrams, we should be focusing on psychological and physiologic response. So ASA1, I think, asks how long should the effects of lisdexamphetamine last? So for most people, the benefits of Vyvanse last about 12 to 14 hours. And I do go into this in detail in my talk on Vyvanse. One of the interesting things about Vyvanse is that the rate limiting step, what determines how much dextroamphetamine is floating around in your body, is how quickly or the capacity of the red blood cell enzyme to cleave it off. And for most people, at some dose, you will be pushing more Vyvanse into the body than you can produce dextroamphetamine at the end side because you've just saturated what the red blood cells can do. And that means taking dosages above that, above the point where you've saturated the rate limiting step, means that you are extending the duration of action rather than elevating the peak higher. That at some point the red blood cells just can't churn out dextroamphetamine any faster, so you're not getting a bigger effect. You are extending it because they'll get around to it when they're finished chewing up what they're chewing up now. So there are ways by going higher to extend the life for some people for Vyvanse. Richard asks, how can I improve communication between the left and right hemispheres of my brain? So I'll sort of recommend, as a primer or basic, going to my video on the left brain, right brain, and I'm forgetting it's a Mick, the neuroscientist who's written extensively about this. I'd say the most useful thing I have found is just being aware that they are sort of substantially different modes of making sense of the world. And again, the left brain tends to be logical, reductive, seeing the pieces and trying to put those, making sense from individual pieces, and the right brain is more holistic and integrative. And I've seen many more people, and we could argue probably many more societies. Left brain serves really important functions, but it also tends to get people into trouble and also tends to help make them add to difficulties in acknowledging that they are in trouble. So Slayman, and I should mention, I do have a firm cutoff in 7-8 minutes. Sleeman, can long-term use of benzodiazepines alongside stimulants help prevent the development of tolerance to benzodiazepines? I don't know any long-term, I don't know any rigorous research on that. I would expect not, because I would expect that most of the tolerance of the GABA A subtype is due to blockade, interfering with that receptor binding site, the benzodiazepine receptor binding site, and what else is going on, and that's a more, I would say, direct, localized effect, and not caring as much what's going on with other circuits or other parts of the brain. But I don't know if there's rigorous data, and usually it's discouraged. I've seen a handful of people, most of whom came to me on this combination, and some could be weaned off one or the other. And some of those felt better, and others who all attempts to change the regimen felt that they were functioning less. But it's often criticized as you're using the stimulants to bump you up, and then you're using the benzodiazepines to calm you down. And maybe that suggests that one or the other is extraneous, and you really only need to push in one direction. Why would we assume everyone's brain or many people's brain only need to push in one direction is itself an assumption that doesn't seem particularly logical to me. Is Broca's area considered part of the prefrontal cortex? I would say yes. So Musker asks, is it possible for someone to have very good or above average working and good recognition memory, poor recall memory, but also have ADHD? So thanks, Max provided the name of Ian McGilchrist as the big writer on and neuroscientist and psychiatrist who's written about left brain, right brain differences. So getting back to Musker's question. So so there can be a great diversity and unevenness of strengths and talents and abilities and different, we know many of these executive functions are the product of fairly discrete and separate circuitry. So good or average working memory could coexist with poor recall memory. It's a different set of mechanisms for recall than for holding it in your mind. So my simple answer, and maybe is yes. People with ADHD can have an uneven profile. Um, and Jonathan's lamenting that they were okay for real. And I don't want to get too metaphysical, but I'd say a large part of reality is what you make it to be. And I also tell people that except for the 7 perfect people on this planet, none of the rest of us are perfect. I frame it that way because if you just say, nobody's perfect, nobody ever listens to that because it's so trite. If you say, oh, there's, except for the 7 perfect ones, that usually makes people really think, are there really 7 people who are perfect? Who could those be? And then they go through the list of heroes or idols or anyone else, and none of them are perfect. So part of the human condition is not being perfect, and part of the struggle of life is dealing with what your imperfections are. And I'd say blanking on what it's called now, the serenity prayer has, I think, a huge amount of wisdom. That is to accept the things that you can't change and work on changing the ones you can. So there might be aspects of your imperfectness that are unchangeable, and those need to be accepted. And there may be aspects of your imperfectness that you can do something about. And probably there are well-established pathways for helping with that. So I'm not seeing any more questions coming in, but thanks for all of you for showing up and asking a good range of questions. I will try to do some research on the ones that I didn't have very good answers about, and stay happy and healthier than I am right now. And I'll be back next week, same time, same place.